So I welcome you all for today's webinar, and that is on a very important topic, that is pulmonary rehabilitation, current trends, and way of rehabilitating a pulmonary condition. So although we all don't have that opportunity of getting such type of conditions where we go for a advanced method of pulmonary rehabilitation, and the facilities are restricted to certain centers only. Not all centers have that much of opportunity to have exposure to pulmonary rehabilitation. So, however, this is important part as far as the physiatrist point of view. For that, we have today's speaker, Dr. Harshanand Popalwar. He's young and aggressive physiatrist and work in multi-dimension. He has keen interest in surgical rehabilitation as well as this emergency medicine or ICU rehabilitation, including pulmonary rehabilitation. His credits of arranging midterm CME for us is a example for everybody how beautiful he has arranged in his own center. He has a lot of academic credits to his academic career. So he has awarded with certificate of merit by Maharashtra University of Health Science, Nasik, for first place in MD PMR examination, and also best paper presentation award at second annual conference Mumbai Association of PMR. He has a lot of articles or publications to his credit, and he has also written one beautiful chapter on pulmonary rehabilitation in our own textbook of IAPMR. Also, he has contributed as an author of IAPMR guidelines to manage child and adult with cerebral palsy. So there are n number of academic credits to his career. So without wasting much time, let me invite Dr. Harshanand, who is important person behind all types of Zoom webinar we are conducting. He's man behind the screen and arranging the platform for us, publicizing it in the YouTube also, and so that you all are getting the benefits of this webinar. Whoever is missing this webinar also, he can attend. He can go through the presentation later on through YouTube. So thank you, Harshanand, for accepting your invitation, and I invite you for start your talk. Over to you. Thank you.
Thank you, sir. Very good evening to all of you. Thank you, Sahoo sir, for kind introduction. As sir has emphasized, in PMR, they say that there is a longitudinal growth and transverse growth, or I would say new pain medicine, musculoskeletal ultrasound management, new interventions. We are going longitudinally, but at the same time, our core rehabilitation is cardiac rehabilitation, pulmonary rehabilitation, pediatric rehabilitation, neuro rehabilitation. We should progress. We should stick to our core physiatry also. Both the balance is important for the overall growth of our specialty. In this line, today's webinar is on pulmonary rehabilitation. So I shall be presenting today's webinar. Sir, I'm sharing my screen, sir.
Sure, sure.
Yes. Is it visible, sir?
Yes, yes, it's well visible.
Yes, sir. So shall I go ahead, sir?
Sure, sir. Please go
Yes.
ahead.
Yes. Once again, good evening to all of you. And I shall be presenting on pulmonary rehabilitation, the current trends. This webinar is exclusively meant for postgraduate students. As I can see, maximum attendance is of postgraduate students, as well as those physiatrists who want to start a pulmonary rehabilitation unit at their respective places. I'll try to guide and I'll try to cover all these aspects for same. So today I shall be covering on the brief history of pulmonary rehabilitation, how it has evolved. Then what's the prevalence and types of pulmonary diseases briefly. Then definition and benefits of pulmonary rehabilitation. Then assessment for the pulmonary rehabilitation, execution of pulmonary rehab program, setting up of a pulmonary rehabilitation clinic. What are the requirements for the same? and what is the current trends and future scope. So friends, there is a why there is a difference between these two individuals. One is a high performing athletes and another is a person who is having a sedentary lifestyle. So there is a definitive difference of aerobic conditioning capacity and overall strength and endurance. So the capability of high work performance can be attained by proper conditioning of the body by regular exercises and other exercise program. So the question is, can we utilize these performance improvement skills or exercise therapy in the patients of having COPD and other crippling respiratory diseases? So answer is yes. Yes, the pulmonary rehabilitation exactly deals with this core concept of utilizing this conditioning exercises. So let's move ahead with this brief history of pulmonary rehabilitation. The history is quite interesting. As you can see, Dr. Avlan L. Barach is the American physician, then pulmonary medicine specialist. He first said that progressive improvement in ability to walk without dyspnea might be physiological response similar to training program in athletes. Dr. Avlan L. Barach, he is the first guy who started using oxygen for the treatment of various diseases. Way back in 1920, he started this oxygen tent concept, where the patients is having COPD and other respiratory diseases. He used to create a tent and with the elevated extra pressure of oxygen to absorb the CO2. He started putting this sodium bicarbonate crystals and all, so that patient should be get benefited. So he's having a number of credits in terms of use of oxygen therapy in respiratory diseases. And he laid the foundation stone of the pulmonary rehabilitation program. Then again, this very famous pulmonary medicine specialist, now in USA, they call him as father of pulmonary medicine in USA. So Dr. Thomas L. Petty, he is the first guy who started standardized outpatient program of pulmonary rehabilitation. Other than pulmonary rehabilitation, Dr. Thomas L. Petty is the person who coined the term called ARDS, acute respiratory distress. And he published around 36 paper on ARDS, and he at the beginning he stated that this positive expiratory pressure ventilation, that is PEEP, should be the gold line standard of treatment way back in 1960s. And still, it is the first line of treatment for ARDS. We have seen in ARDS cases, mostly in COVID-19 pneumonitis and all. So all credit goes to him. And again, he had a lot of wonderful work in pulmonary rehabilitation. Then in 1974, this American College of State Physicians, they formulated a definition of pulmonary medicine. And way back in 1980, the American Thoracic Society, that is ATS, they issued an official statement in which pulmonary rehabilitation components were described and all the benefits were specified. Again, in 1999, ATS published 40-page documents stating the importance of pulmonary rehabilitation and a broad protocol how to use it in clinical practice. Again, this global initiative for chronic obstructive lung disease, that is called GOLD, they published guidelines way back in 2001 and as a standard and established treatment for COPD. In 2003, pulmonary rehabilitation was included in the algorithm for the management of stable COPD. As you can see into the second image, in the moderate category, there is a incorporation of pulmonary rehabilitation program. Then ATS revised guidelines way back again in 2013, and the latest guidelines they have published in 2023. They are free of cost download. Around 60-page document is there. It is available on the ATS website. All the PG students and interested physiatrists can go through this. I shall be talking on this latest 23 guidelines at the latter part of this presentation. So now the prevalence. As per WHO, around 65 million people have moderate to severe COPD. That accounts for the 5% of death globally. And the COPD remained the most prevalent disease-specific chronic respiratory disease. If you see the Indian scenario or developing country scenario, India contributes very significantly for the mortality from the COPD, significantly affecting health-related quality of life. This was the meta-analysis published in Lung India 2021. Last they said that estimated prevalence of COPD in India was found to be around 7.4%. It is quite high. As we all know, the pulmonary diseases in MBBS curriculum we have seen basically divided into two major categories: obstructive pulmonary diseases and restrictive pulmonary diseases. In obstructive pulmonary diseases, as you can see, reduced vital capacity, inspiratory reserve volume and expected reserve volume, and increased residual volume. So these are major four categories: emphysema and chronic bronchitis, asthma, bronchiectasis, and cystic fibrosis. Each disease have their own etiopathogenesis and mechanism of, but they are broadly covered under COPD umbrella term. Then again is restrictive lung disease. As you can see, there is reduced vital capacity, residual volume, FRC, but in restrictive lung diseases, the major categories like idiopathic pulmonary fibrosis, sarcoidosis, scoliosis secondary to multiple skeletal or neuromuscular, and ALS and other diseases where there is a overall lung restriction is there. So to go ahead with what's the pulmonary rehabilitation, the definition, this is nice definition. There are multiple definitions available on internet, but these are most commonly I prefer to use this. Pulmonary rehabilitation is a multidisciplinary program of care for patients with chronic respiratory impairment that is individually tailored and assigned to optimize each patient's physical and social performance and autonomy. That individually tailored is a most important component or aspect, because every patient have different presentation, they have different aerobic conditioning capacity, MRC scaling will be different, and other parameters may be different. So what are the broadly benefits of pulmonary rehabilitation? So this is again taken from the CHEST 2007 guidelines. Although there are revised level of advance is there, I shall be discussing at the later. So to briefly, quickly summarize, pulmonary rehabilitation improves dyspnea, it's level 1A recommendation, then improves health-related quality of life, then it is beneficial for some patients with chronic respiratory disease other than COPD also. Then it reduces the number of days spent into the hospital, it provides psychosocial benefits, it is very much cost effective, and but there is at the same time this insufficient evidence regarding this improvement on overall survival of the patient. There is no such recommendation. So quickly to summarize, it improves exercise capacity, it reduces perceived intensity of dyspnea, improved health-related quality of life, reduced hospitalization, reduced anxiety and depression, etc. Now, pulmonary rehabilitation team. In most of the setups where the pulmonary medicine specialist is there, many a times there is no physical medicine and rehabilitation specialist. Most of the time, respiratory therapist or physiotherapist, they come into the picture. But ideally, I personally believe that this should be the ideal setup where the pulmonary medicine specialist, PMR specialist should go hand in hand. The primary assessment and prescription of pulmonary rehabilitation has to be done by physical medicine and rehabilitation specialist, and then it has to be followed from the physical therapist, dietitian, and psychologist, other components, team members. So outline of pulmonary rehabilitation program. So it starts with patient assessment, patient education and motivation, patient exercise training, program evaluation, and maintenance. So the it start with medical history, that is chief complaint, duration of illness, total episode of dyspnea. Then we need to assess the smoking status, perform spirometry for our pulmonary function test before and after pulmonary rehabilitation program, documentation of medication started by pulmonary medicine specialist. Then the simple 6-minute walk test before and at the end, and then quality of life. Can use this chronic respiratory disease questionnaire or St. George respiratory disease questionnaire. Both the questionnaires are available on the public domain, but we need a prior permission for the same. And then modified medical research council dyspnea scale or MMRC scale. Then we need to calculate the targeted heart rate, 220 minus age. That's a simple formula. And accordingly, 80 to 85% of targeted heart rate we are supposed to achieve. So basically contraindications for pulmonary rehabilitation is there are these major contraindications like angina pectoris, unstable angina, recent myocardial infarction, severe pulmonary hypertension, CHF, uncontrolled diabetes, then psychiatric illness, exercise-induced hypoxemia, lack of motivation, and non-adherence to this. So basically, the cardiac conditions we have to taken care of, and we are not supposed to advise in such type of patients. Then patient should be evaluated for these contraindications and precautions for exercises, and the supervisory staff should be aware of the criteria for the termination of a test and other important safety issues. This is key important. Our staff and subordinates, they must know when to stop and when to report. Then we are supposed, as per the assessment, we are supposed to set a realistic goal. For example, if the patient is MMRC scale grade 4 or 5 dyspnea, and we can't expect the patient to run on the marathon. So we, after assessment, we have to discuss the patient, our goal to the patients as well as family members, what exactly approximate outcome we are expecting. Then for the execution of pulmonary rehabilitation program, we are supposed to start with first patient education. We need to tell them what exactly disease is and what are the outcome at the end of pulmonary rehabilitation program. We must optimize the medical management. We must advise the diet advice or nutritional advice, then secretion management. If there are secretions, then we must start this breathing techniques, use of oxygen, nebulization, physical reconditioning exercises, and at the end, we are supposed to do assessment outcome measures. So we can have such type of flyers. This was I made at the Safdarjung Hospital, where we have started the pulmonary rehabilitation clinic. So through patient education, through leaflet, through videos, patient can become have a more skill at collaborative self-management, and there will be more adherence to the pulmonary rehabilitation program as well as our treatment plan. So as I said, we can give education through multiple. Group therapy session is, again, I would like to recommend 3 or 4 patients can collectively sit together and we can guide them regarding the same. Then other educational topics maybe includes sputum clearance, then energy conservation techniques. We must start swallowing, home oxygen, and sexuality issues. Then optimization of medical management. The practical scenario I would like to emphasize on this, that many patients, they write 3 or 4 MDI or spacer, and because what personally I have seen to my patients, many times they don't know the correct techniques, because in OPD, especially in pulmonary medicine OPD, they just write the prescription. When the patient gets this MDI, nursing officer many times, sometimes they don't know how to exactly use that, so that there will be inadequate. Many times if you don't press the MDI and simultaneously you don't inhale, the drug deposition will be at the posterior wall of the pharynx, and drug delivery will not be to the properly inside the lung. So many times, in spite of having 2 or 3 MDI and other medications, patient doesn't get relief. So this is also important aspect of the pulmonary rehabilitation program, where physiatrists can properly taught at the first visit. Regarding, and secondly, what medication pulmonary medicine specialist has written, we must know, and we must know about how to readjust accordingly. We can consult with the pulmonary medicine specialist regarding the medical management. As I discussed, so as where this is in the, as per this gold COPD guidelines, we can the pulmonary rehabilitation can be started into the moderate to severe or very severe disease of COPD. Then this is again taken from the gold guidelines, where there are multiple medications. You can go through this chart: short acting beta agonist, then anticholinergic, short acting and long acting, then combination of short acting beta agonist plus beta plus anticholinergic drugs, then other methylxanthines, combination of long acting beta agonist, and other multiple medications are available. We are supposed to thoroughly know all the dose and approximate medications. Then nutritional advice is very important for the patients. I'll tell you why exactly it is important. It is a fundamental in rehabilitation. So in COPD patients, there is a pathogenesis of increased calorie expenditure. The COPD patient needs more calories for the work of breathing. So increase work of breathing, increase energy expenditure into the very act of breathing, because intercostal muscles are continuously working, continuously exerting, and because of that is a loss of calorie expenditure. So resting energy expenditure, that is called REE, it is elevated in the state of increased work of breathing. So approximately 450 to 700 calories are essential, important for the patients who are suffering from various types of COPD diseases. Then the simply high protein, high carbohydrate diet we are supposed to advise accordingly. If the patient is vegetarian, then soya milk, soya bean, and other vegetable proteins we are supposed to advise to the patient. Then bronchodilation before the pulmonary rehabilitation program. At our setup, we generally start simply nebulization along with acetylene. So in before that, we are supposed to remove the secretions, followed by bronchodilation. We can simply if the acetylene and other issues are having some problem, so we can simply nebulization with the normal saline. Then, as I said, secretion management is again important component of the pulmonary rehabilitation. As a PMR expert specialist, we must know how to do, and I would recommend that initial 2 or 3 settings, secretion management we are supposed to do, and followed by after stabilization of the patient, we can hand over the patient to the respiratory therapist. So as you all know, the gravity assisted positioning, that's called postural drainage, is important. We must know the normal anatomy of the lung, what are the different lobes and segments, and how to drain according to the different position of the postural drainage. It should be best done after awakening in the morning, because if you remove the secretions, then the day will be good for the patient, and just before the sleep also, so that patient can have a good sleep at night. So these are various different techniques where this at what position gravity assisted posterior drainage would according to the various positions we are supposed to follow. So to dislodge the secretions, there are multiple ways. So mechanical hand cupping is also bestly important. So we are supposed to simply vibrate the cupped hand and according to the different segments and different positions according to the gravity assisted. Generalized frequency would be 15 to 20 vibrations. So you are supposed to strongly vibrate that particular segment and dislodge the secretions. You are supposed to tap it accordingly at the different lobes of the patient. This will loosen the thick mucus plug and remove the help the patient to get it removed. Again, advanced air cleaning technique. Now we have dislodged the mucus plug and how to exhale it. So this is a very conventional thing that is called control cough, where what we are supposed to do, we are supposed to close the glottis. We'll put one hand or abdomen on the pillow and increase the abdominal pressure, and you are supposed to cough like this, like this. So, but the disadvantage of this controlled cough technique is that sometimes diaphragm is not that strong and it can cause the injury, especially in case of emphysema and all, where there is an entrapment of the airways because of emphysema. So you may not be able to get it. So I would definitely recommend this huffing technique to remove the secretions. What you are supposed to do in huffing, you are supposed to open the glottis and increase the frequency of coughing, just like this. Periodically. So ha ha ha, you can simply say ha ha ha. So contract the abdomen and remove the secretions slowly. Patient can frequently spit out the sputum accordingly. These two things, postural drainage, chest physiotherapy, is supposed to do before starting of pulmonary rehabilitation program, then nebulization, and then actual aerobic conditioning therapy. Then again, rapid handshake, as I said, we can also do with the or chest PT vibrators are also available into the market. Some new devices, as you guys know, this acapella is a registered trademark. So basically, this is called positive expiratory pressure. These are the devices, they are very useful. A lot of my patients, they are using it. So what you are supposed to do, you put the mouthpiece and you specifically exhale this thing. So the moment you exhale, this vibrations will slowly go to the tracheobronchial tree inside to the all the terminal segments or terminal bronchioles, and they will help the patient to dislodge the secretions. This is very much useful for the patients of emphysema and all. Then again, latest trend, which is now this is the device which is available. Boxer company is marketing in India. It's called Waste Airway Clearance System. As you can see into the image, there are two these things. So this they will put this jacket over the lung and they will create a vibrations of different frequency. You can use this device for the ICU patients and other debilitating normal patients also. So this will help the patient to dislodge all the secretions from all the lobes, and you can spit it out with the huffing technique. Then again, use of oxygen. Again, this is important. If your setup doesn't have direct oxygen lines or centralized oxygen lines, you can simply use the oxygen cylinder for your patients. So OT is recommended for the patients when they desaturate during the exercise training. So if the SpO2 saturation goes below 90% during exercise training, then you must administer with the nasal cannula. If the patients are having COPD, or if the MMRC scale is, or Bose scale of intensity of dyspnea is, I would say, impaired or very in deranged category. So I initial for 1 week, I generally advise the prophylactic nasal cannula and simple 1 liter of oxygen. This helps the patient to get the confidence, and it improves the overall endurance of the patient. Then control breathing technique. Yes, again, this is important because COPD patient exhibit an altered pattern of respiratory muscle use. The rib cage inspiratory muscle generate more pressure than the diaphragm as diaphragm gets flattened. And so because of that, control breathing technique are essential or helpful for the patient to work more efficiently. So diaphragmatic breathing, as you can see, one hand is to be kept on this chest, another hand is to be keeping on the abdomen. Now, in this video, you can see the patient is lying supine and the abdomen is going up and abdomen is going down. So in case of the patients who get acclimatized, you can reduce the head height like this so that abdominal content will press the diaphragm, and you can start this diaphragmatic breathing exercise in tilted declined position of the patient, where head end will be the at down. So the patient takes deep breath and expands the abdomen using the diaphragm. Then what are the benefits of diaphragmatic breathing? It increases tidal volume, decreased functional residual capacity, and increase in maximum oxygen uptake. Then segmental breathing, the patient basically asked to inspire while the clinician applies pressure to the thoracic cage to reduce respiratory exertion in the segmental lung. As you can see into the video, we are supposed to put that at various segment, and the clinician feels the excursion or expansion of that particular segment of the lung during the act of breathing. So this is very much useful for the interstitial lung diseases, where there is a particular segments are affected and you want to put the more air and expansion into the that particular segment. So this is segmental breathing is very much helpful for the patients of interstitial lung diseases.
നമ്മളെ സൈക്കിൾ ഉണ്ടല്ലോ, സൈക്കിളിന്റെ ബെല്ലുണ്ടാവും.
Sorry, my slides are not moving. Sir, can you hear me, sir?
Yes, I can hear you. Slides are not moving. It is in segmental breathing.
Yes, sir.
That
Yes,
slide
actually,
is in-
my laptop got hanged. 1 minute, sir. 1 minute, sir.
Sure. Please.
Hello. Are my slides are visible, sir?
It's visible, but not in the slideshow mode. Can you change to full screen view now?
Now, sir?
Yes. Now it's
Yes.
full screen mode.
Yes, sir. Now, can you hear me, sir, now?
Yes.
Yes.
We can hear
Now,
you.
pursed lip breathing, sir. Yes. Thank you, sir. In pursed lip breathing, patient inhales through the nose for a few seconds and exhales through the mouth, as you must have seen into the video, where you are supposed to inhale through the nose, and for the longer duration of approximately 5 or 7 seconds, you are supposed to exhale. This is very much essential for the patients of emphysema, because in emphysema there is air trapping is there, and oxygen is get entrapped inside the lung, and because of that there is no ventilation and patient desaturates. So after secretion removal, pursed lip breathing is supposed to be advised exclusively for the patients of emphysema. So benefits, it prevents air trapping, as I said, due to small airway collapse during exhalation, and promotes greater gas exchange in the alveoli. It can be advised 15 to 30 repetitions daily at 4 hours of interval for 5 days a week for the severe or chronic cases of emphysema. Now, inspiratory muscle training we can do with the multiple various types of incentive spirometer, as you can see into the video. So basically patient is supposed to inhale and lift the ball, and at the same time patient can exhale also, and patient can throw the balls also. So incentive spirometry with inspiratory, we can change the resistance of the aperture, and accordingly the patient can increase or decrease the strength. Now latest new models are also have came where there is a automatic resistance is there. But slides are not moving, sir. Sorry, because I think because of video, it got yes. Now use of peak flow meter. Where this peak flow meter, there is you can see green, yellow, and red is this thing. So at the beginning, we can, with the help of peak flow meter, we can find out what is the expiration capacity of the patient, and accordingly we can set the target. After 1 week, you are supposed to achieve this much of level, and after at the end of pulmonary rehabilitation, this much should be the target of the patient. Yes. Then now this comes physical reconditioning exercise program. So the progressive deconditioning associated with inactivity, it initiates a vicious cycle. Because of disease, patient is deconditioned, and because of deconditioning, disease increases. So this physical reconditioning, this cycle has to be broken by the physical reconditioning exercises, and this is what we do in institutional-based pulmonary rehabilitation program. So the flow chart is like this. Because of chronic respiratory disease, it leads to dyspnea, dyspnea to inactivity, leads to deconditioning, worsening of dyspnea, disability, and death. Physical reconditioning. So exercise conditioning is the most important factor in rehabilitation of patients with symptomatic respiratory diseases. So what are the exact effect of well-defined pulmonary rehabilitation program? So as we have studied the physiology very back in first year of MBBS, and even in sports physiology, we study what is the role of aerobic conditioning. So here, increase maximal oxygen uptake, increase bulb volume, increase of hemoglobin level and stroke volume, improvement in the peripheral use of oxygen, increased muscular strength, improved blood and energy supply, then improved muscle coordination, change in body composition with increased muscle mass, improved sensation of well-being, and the possibility of increasing chance of survival and reduction of all the dyspnea and symptoms. So the same effect of physical reconditioning is beneficial for the patients of COPD and other restrictive lung diseases. So what is the specificity of training? There's two in category divided into strength and endurance training. Strength training achieved by increasing myofibrils in certain muscle fibers, and endurance training increases the number of capillaries and enzymatic mitochondrial content in the trained muscle. So the flexibility and warm up. So simple warm up patient can do. You can see into the videos. So static stretching of all major muscles and simple warm up exercises 2 to 3 days a week, ideally for 5 to 7 days, 50 to 30 seconds of exercises, 2 to stretching exercises, and intensity of stretch to the tightness at the end of the range of motion, but not to the pain. This should be the overall stretching exercises. Then cardiorespiratory endurance training, strength and muscle endurance, and flexibility. They are the AC, American College of Sports Medicine guidelines for exercise prescription.
Now also
Yes,
slides are not moving. Yes.
Yes. Sorry for this technical glitch. I don't know why it is getting stuck. I think maybe because of video, sir. So cardiorespiratory endurance training can be done with this simply recumbent cycle or cross trainer or simple treadmill. So the as I said, so a large group of muscles we are supposed to target. Then frequency will be 3 to 5 days a week, or at least 3 times in a week. Duration should be approximately ranging depending upon from the 20 to 60 minutes per session, and the heart rate should be targeted at the beginning 50 to 60%, and at the end of pulmonary rehabilitation program, it can increase up to the 85% of targeted heart rate, and rate of perceived exertion should be 12 to 16. Then strength and muscle endurance training, we can do variable resistance. We can use simply dumbbells or other hydraulic machines, or simply you can use the simple water bottle also, or any other free weights. So frequency 2 to 3 days a week, one set of 3 to 20 repetitions, 8 to 10 exercises. That includes all the major group of muscles. Here, all the accessory respiratory group of muscles we are supposed to target. That includes sternocleidomastoid, trapezius, latissimus dorsi, rhomboids, and intercostal muscle pectoralis major and minor. So these muscles are supposed to be targeted mainly so that the work of breathing shall be eased. Yes. So the total duration of program should be 5 days a week, or minimum 3 days a week for 8 to 12 weeks. Here at our center, we call the patient thrice a week for approximately 30 to 40 minutes at the first week, and we can stretch the overall duration to 1.5 hours 3 times a day for approximately 12 weeks. So at the end of the pulmonary rehabilitation program, the assessment outcome would be change in sputum production, change in breath sounds of lung field during being drained, change in overall vitals, change in ABG analysis, arterial blood analysis, improvement of dyspnea, fatigue, and improvement in the health-related quality of life and psychological symptoms. So these are our assessment pro forma, where what details we do, the initial patient assessment. This includes history taking, family history, past history, smoking history, and all the vital parameters. Then this is a rehab protocol. We start with patient education and counseling regarding this information about the disease, nutritional, dietary advice, counseling in case of any anxiety or depression, take the help of the clinical psychologist or psychiatrist. Then explaining the patient's in terms of physical activities and information about the various energy conditioning techniques. Then special interest in that we advise various types of breathing, which type of breathing retraining we are supposed to advise. If required, we can ask the patient to have oxygen therapy at home also. Then these are various warm-up exercises, stretching exercises. Then proper aerobic conditioning exercises where we have this cross trainer, treadmill, and recumbent cycle. We start with 5 minutes of warm-up exercises, then moderate or mild to moderate speed of cycling or treadmill walking or recumbent cycling, and cool down. Then strength training, we have various group of muscles where we can target and follow assessment at the outcome at the end of 0 or at the beginning, 6 weeks and 12 weeks. These are pro forma for the 6-minute walk test before and as well as end of the program. And this is the MMRC scale. And then these are simply rehab attendance sheet where 12 weeks pro rehab program, how many times patient has attended, and other parameters. So now, this is for the young physiatrists where they want to start this pulmonary rehabilitation clinic. So want to little bit focus more on that because I believe that it is very easy to set up. We don't need a high fancy equipments for the same, and it can be executed in very smoother way. So to just like any other setup, there are the basic things where we require that includes infrastructure, manpower, equipments, and we should have our own standard operating procedures of your respective pulmonary rehabilitation unit. So approximately hall of 400 square feet with air conditioning is important because many a times patients get a lot of perspiration, dehydration, and many a times they get breathless and dizzy. If possible, if you get an air conditioned room, that is good. If not, still you can start the patient. And approximately the room should have a capacity of approximately 4 to 6 patients. These are unit, common area unit, but we are starting we are doing pulmonary rehabilitation at our this treadmill and recumbent cycle area. Then manpower, you need to have a good coordination with the pulmonary medicine specialist because they are the person who you must inform that what exactly you do so that they can send the patient to you. At our Safdarjung Hospital, Delhi, we had a very good response from the pulmonary medicine department. Here at AIIMS, Nagpur also, the pulmonary medicine specialist, they are very happy to send the patient because they also know the importance of pulmonary rehabilitation and ultimately their patients are going to get benefit. Then PMR specialist, then physical therapist. If you get a respiratory disease, that is well and good. Even if you don't get simple BPT person, you can train the person and you can continue the pulmonary rehabilitation setup with the help of them. Then a staff nurse has to be there, especially for this nebulization and other procedures. Then nursing attendant will be good and simple housekeeping working staff. They're the ideal things, but you can, depending as per your requirement and availability of resources, you can readjust accordingly. Then equipments, they are divided into basically 3 categories. Equipments or tools for assessment, equipments for therapy sessions, and equipment for in medical emergency. As an NABH guidelines and other multiple guidelines, at least the person who is doing CPR must be knowing them, and ambu bag and other intubation tray has to be there along with life sink or crash cart has to be there. That is the mandatory requirement. Although the incidence of exercise-induced bronchospasm is very less. I would say 1 in 10 lakh patients. But you must have backup of this emergency equipment also. Then equipments for therapy sessions and medical equipments. So in equipments for therapy sessions, you can have, as I said, therapy sessions, you can have simply a postural drainage table. If not, you can simply use the normal bed and various pillows for various positioning. Then secretion removals, you can have a chest PT vibrator, or you can simply use the cupping techniques or hand techniques. Then nebula for the nebulization purpose, you can have nebulizer simply. Along with that, other aerobic conditioning, simply cross trainer or recumbent cycle or treadmill is also there. And for strength training, dumbbells, simple dumbbells, or if dumbbells are also not available, you can have simply water bottles or any other free weights. Then, as I said, equipment for medical emergency, I have already explained. So, the protocol or action plan or SOP, the identification of symptomatic chronic lung disease patient, then optimize their medical management and maximize the medical therapy using existing medications. You can consult with the pulmonary medicine specialist. Then we need to rule out any medical, psychological, musculoskeletal instabilities or contraindications for the same. Then when enroll the patient, then have patient education and counseling about the pulmonary rehabilitation program. Assess the accessibility, the feasibility, and affordability. For example, at my place, the major hurdle is that my AIIMS Nagpur is 15 or 20 kilometers away from the main city. So many times traveling thrice a week from the city to the main your pulmonary rehabilitation center is very difficult. So institutional based pulmonary rehabilitation has certain limitations. Then pre-program assessment, as I said in briefly, then initiate pulmonary rehabilitation program and motivation of the patient participant to achieve goals of pulmonary rehabilitation program, and home care continuation of the pulmonary rehabilitation program at home. And you can call the patient every thrice a month for reassessment or follow-up. So now the question is that low-cost pulmonary rehabilitation program for COPD, is it good? So this was the paper published in our journal IJPMR way back in 2006, and they said that substantial benefit in objective measures of dyspnea and exercise tolerance can be achieved with a simple low-cost pulmonary rehabilitation setup. So recently we published this paper. One of our DM students at Safdarjung Hospital, he did his thesis on this clinical utility of pulmonary rehabilitation in diffuse parenchymal lung diseases. As there is a level 1 evidence for the COPD and other thing, but for the diffuse parenchymal lung diseases, he studied that whether the beneficial or not. We studied this prospective intervention study where this institutional-based pulmonary rehabilitation program was 12-week program was underwent in hospitalized supervised pulmonary rehabilitation program, and assessment measure was outcome measure was assessed at the end of the 12 week, and it shows that there is a significant improvement in respiratory capacity, forced expiratory volume in 1 second FE, that is FE1, and then 6-minute walk distance, modified Medical Research Council MMRC gradings, and St. George respiratory questionnaire scores. So they concluded that PR is effective in people with diffuse parenchymal lung disease also in decreasing the symptoms and improving the exercise capacity and quality of life. Now, another thing, this telemedicine-based pulmonary rehabilitation. As we all know, telemedicine right now, the multiple platforms are providing, like Tracto and other, they are providing consultation and for various diseases. The telemedicine-based pulmonary rehabilitation program shall be game changer. And for me to work in this area was the COVID-19 was the main triggering factor for us to work on this aspect. So as it just in the middle of the first wave, this telemedicine practice guidelines have been published by this Ministry of Health and Family Welfare in 2020. And the telemedicine brings the healthcare service at the doorstep for the patient or common people. So for the institutional-based pulmonary rehabilitation program, there are multiple difficulties have been faced by the patient. They're all practical difficulties. There may be a lack of transportation because someone has to bring for the patient to get the patient from home to your setup, institution setup. Then there are other comorbidities also. For example, if the patient is having ONE and other issues, the lack of their perceived benefits or socioeconomic status, they don't have money, they don't use the common transport like bus or train, so they have to get their own vehicle, and lack of funding facilities. So all these above barriers can be tackled with the meticulously defined pulmonary medicine, telemedicine-based pulmonary rehabilitation program. And this telemedicine-based pulmonary rehabilitation, it have a huge potential for the larger population, but it comes with their certain own limitations also. So in COVID-19, one of our MD students did thesis on this, and we published this in Indian Journal of Family Medicine and Primary Healthcare. So the study of effectiveness of telemedicine-based pulmonary rehabilitation program in recurrent COVID-19 pneumonitis. So where the objective was to determine whether telemedicine is effective in COVID-19 pneumonitis all. So intervention, we did 6 weeks of telemedicine-based pulmonary rehabilitation program. Our results were like 6-minute walk test, MMRC scale, 30-second sit to stand scale, WHO quality of life, all were improved. And we concluded that the 6-week pulmonary rehabilitation program delivered through telemedicine platform improves respiratory function, quality of life, and anxiety in patients of COVID-19 pneumonitis. So as I said, now this American Thoracic Society has given this latest recommendations. These are the basic recommendations. They framed around 6 questions, and this working group or expert group, they deliberated on this, and they found out various levels of evidence. So the question was that should adults with stable COPD undertake a pulmonary rehabilitation? Recommendation is yes. For adults with stable COPD, we recommend participating in pulmonary rehabilitation program where there is a strength of quality of evidence is strong and strong along with moderate. The second question was, should adults with COPD undertake pulmonary rehabilitation following hospitalization for an exacerbation? The recommendation is, for adult with COPD, they recommend participation in pulmonary rehabilitation program following hospitalization for the, again, the evidence is strong to moderate. And should adult with ILD, that is interstitial lung diseases, undertake pulmonary rehabilitation? There is a, again, they are recommending the pulmonary rehabilitation program for the interstitial lung disease also with a strong to moderate evidence. Then should adult with pulmonary hypertension should undertake pulmonary rehabilitation program? So the level of evidence is low because the pulmonary hypertension, the pathophysiology is totally different. But again, they are not denying that. Then fifth question is, should adult with chronic respiratory disease undertake telerehabilitation? Again, so they have done a lot of deliberation, and you can see they say that there is a strong evidence, and they recommend for adults with stable chronic respiratory disease, they recommend offering the choice of center-based pulmonary rehabilitation or telerehabilitation with a strong evidence. And the sixth question is, should adult with chronic respiratory diseases undertake maintenance pulmonary rehabilitation? For adult with, they say that the level of evidence is low or it is conditional, and they suggest that either supervised maintenance pulmonary rehabilitation or usual care after initial pulmonary rehabilitation they have been advised. So, to the take-home message, that pulmonary rehabilitation is an integral and essential part of the management of COPD and other chronic pulmonary diseases. Many a times, the pulmonary medicine specialists, they know that this is integral as per the GOLD guidelines and other recommendation, ATS guidelines. It has to be recommended for the moderate and other severe COPD, but because of lack of facilities or because of lack of motivation, they are not recommending. Those centers where the pulmonary rehabilitation facility is there, they're definitely doing this. Then pulmonary rehabilitation is highly effective and beneficial for the patients. And our country needs more pulmonary rehabilitation centers, both institutional as well as telerehabilitation. So I definitely recommend our young physiatrists to read this chapter, chapter number 34 in our own textbook. So thank you for patient listening. And questions are most welcome. Over to you, Sahoo sir.
Thank you, Harshanand, for very practical presentation. You have shown your setup and practical guidelines to be followed for establishing a pulmonary rehabilitation unit. So it is our young physiatrist who was to take interest on that. Somebody is having interest on pulmonary rehabilitation. He has to have good relation with our pulmonologist friend. With their help and confidence, someone can go ahead with that. Before going for question section, I just want to know something regarding this pulmonary rehabilitation, especially as I said, all centers, they don't have that type of facility. They have to have administrative support, financial support to establish a pulmonary rehabilitation center. But every center is dealing with spinal cord injuries. Every physiatrist is dealing with a spinal cord injury patient, especially where that pulmonary rehabilitation unit is not there, dedicated unit is not there. And still we get cases like high tetraplegic patients where expect a frenulum paralysis above C3 level. So even lower level also, C4, 5, 6 level also, because of prolonged bedridden condition, they develop a chest complication. Either it is from high tetra or a lower tetra even. So how to go ahead with this pulmonary rehabilitation in case of high tetraplegic patients with pulmonary complications? Can you highlight on that?
Yes, sir. Depending upon the level of the injury, if the phrenic nerve is intact, if the level is below the C4 or C5, then your diaphragm is intact, sir. So patient definitely need to have proper positioning, prevention of aspiration pneumonia, especially during the post-op acute care settings, and diaphragmatic breathing exercises and periodic chest PT along with if there is any secretions, we are supposed to do this. So I would definitely recommend this diaphragmatic breathing as well as pursed-lip breathing exercises for this patient. I will definitely recommend to have incentive spirometry periodically along with them, because in tetraplegia, especially in acute care, there is no power into the upper and lower limb. But the intercostal muscle and diaphragm, we are supposed to use these things to prevent the aspiration pneumonia. Because I have seen, sir, most of the time when the spine surgeon operates, especially C5, C6, post-op, the patient is stable and they are simply transferred to PMR unit. So there, the chances of pneumonia, as you can see, that is the most common cause of mortality in post-acute care setup, especially in tetraplegia. So routine respiratory care we are supposed to follow for this patient, sir.
And for high tetraplegia, where you expect a frenulum nerve paralysis, how do you go ahead with this?
Sir, then the total line of management will be different, sir. For the high level tetraplegia, we have to do this diaphragmatic phrenic nerve pacing or phrenic nerve stimulation, and BiPAP and other ventilatory support we have to advise to the patient, and we need to treat the patient in that line of management. The total line of management, there will be different game for this high level of tetraplegia. We have to remove the secretions. We have to prevent the stasis of secretion, because if the secretions are there, then there are high chances of superseded infection and pneumonia. So we have to take care of the lung, chest PT, postural drainage, removal of secretions in case of high level of tetraplegia. This should be the standard ICU care respiratory management, sir.
No, beyond ICU care, when the patient transferred to the rehab unit, how do you go ahead with the accessory muscles of that, like that muscle supplied by the spinal accessory nerve, where the cranial nerve is paralyzed? Then how do you manage this type of situations where the high tetraplegia patients?
Yes, sir. In this type of setup, sir, patient, for example, like the supine segmental breathing, where we are supposed to put the therapist or put the patient hands on the various segments, and lung excursion has to be there. We need to train the patient to have accessory muscles of respiration. We are supposed to target that also, specifically as I mentioned into the presentation, like sternocleidomastoid, trapezius, rhomboids, latissimus dorsi, and pectoralis major. So we are supposed to strengthen that this thing also, along with breathing techniques, breathing exercises, segmental breathing, personal breathing, incentive spirometry. In this line, we are supposed to manage the patient, sir.
Okay, we have with us one of another physiatrist, which is very much experienced in pulmonary rehabilitation, Dr. Kaustav Chakravarti. I can see his name. He has put some questions also. Dr. Kaustav, can you unmute yourself and come to board to say something, add to this? Hello, Dr. Kaustav, can you hear me? Okay, so he has put some questions like visual feedback, especially for the illiterate or low vision patients who cannot see the graduations. Probably that is a compliment to your talk.
Okay, sir.
Some more questions. Is there any rationale of prescribing the quadvalent influenza vaccines, or will the trivalent one of the northern hemisphere suffices for our country?
Yes, sir. I think a pulmonary medicine person is the right person to answer this question. But as I can in my setup, sir, this influenza vaccination, they are definitely recommending to each and every COPD patients whose age is more than 60 years. That is annual influenza vaccine. Trivalent vaccines, frankly speaking, sir, I don't have any experience, and I'm not in a position to answer this question, sir. But routinely, I'm seeing that whatever patients pulmonary medicine is sending to us, they are doing annual influenza vaccination compulsory.
Okay. One more question. Can we do postural drainage for intubated patients?
Yes, yes, definitely.
What about the TT care and suctioning?
Tracheostomy care, this routine tracheostomy care, we all know that has to be done periodically. And then postural drainage, intubated patient, yes. But we need sometimes, many a times, we need a nursing staff and attendant support for the proper positioning. If there is no harm to the patient, your tracheostomy is not impinging or not piercing the posterior wall, or any there is no other contraindication. For example, if there is central line is there and you are moving the patient and you are giving the hazard to the patient. So in this overall scenario, intubated patients, yes, definitely you can do postural drainage, but depending upon the situation and depending upon the hospital support staff, definitely this will improve the removal of the secretion.
Okay, this again one more question from the same delegates. How to tap O2, hover on it, and can you explain about PEP device mechanism?
Positive expiratory pressure mechanism, sir. It is basically it's a ventilator where there is a sometimes if there is a impaired work of breathing, then machine gives senses this particular breathing cycle and gives the positive positive air to the patient. So those patients who are there is a impaired work of breathing, this PEEP device. 1 minute, sir. I think this is it about this. Positive expiratory pressure a cappella device the question is asking, or whether it is about this ventilator?
He's asking about the positive expiratory pressure device, I think.
Acha, that one, that's called a couple is the trade name, sir. The simple device is that you are supposed to put it into the mouth. The device have their own vibration mechanism. Once you expel it, at the same time, it produces the vibrations. The vibrations will go to the tracheobronchial tree inside and it dislodges the mechanism. This is very low cost device, sir. This cost approximately 2 to 3,000 rupees. Or there are other companies are also available into the market where you can get this thing. So this will help the patient, especially for this emphysema patients where there is a entrapment of air is there. So this is very beautiful device to dislodge the secretions for this PEEP device patients.
Okay. What is the significance of color code in incentive spirometer?
It's very simple, sir. It's red, green, blue. It shows that red is need maximum resistance, blue and yellow. So just it is the mild, moderate, severe intensity of the spirometer.
Okay. Experienced by somebody is today for him, 8-month-old baby came to the OPD with cystic fibrosis, having recurrent chest infection. How to proceed in this patient?
Yes, sir. So cystic fibrosis, sir, as you know, it's a enzymatic deficiency at this alveolar mechanism, and because of that, a lot of secretions patients get. So I also get a lot of referrals from the pediatric ICU as well as OPD for the cystic fibrosis, especially old babies. So the key of management in cystic fibrosis is removal of secretions. So postural drainage and removal of secretion is the key, where, for example, if the infant is of 8 months, so mother has to put this on prone line, put this hand on this on the face of the baby. The baby will be on the hand, and with the postural drainage, you are simply supposed to, with the help of the 2 fingers, you are supposed to tap posterior segments, then lateral segments. You are supposed to tap and try to remove the secretions from the baby. The baby may cough, sometimes they may be froth. You need to put some suction catheter and remove the secretions. So the key of management in cystic fibrosis is removal of secretions. Because the stasis of secretions cause superseded infection, chest infection, pneumonia, and sometimes baby dies. So in cystic fibrosis, this enzyme replacement therapies, these new things are coming up into the market, sir. But they are also important. But simultaneously, secretion management is again the key in the cystic fibrosis management.
Okay, somebody has requested you to post the assessment and rehabilitation protocol PDF in the group so that they can use that in their own center.
Definitely, I would recommend that I'll upload onto the IIPMR website, sir, under this download section, or the person can, because this is sometimes it's like an intellectual property, they can directly pinch me on WhatsApp and I'll send you individually. I'll share my number here, sir.
Okay. Next, why uncontrolled diabetes is a contraindication to pulmonary rehabilitation?
The standard guideline says that, sir, that uncontrolled diabetes, sometimes because of hypoglycemia or because of sudden hyperglycemia, patient may get faint during the high performance aerobic conditioning exercises. If the patient controls the diabetes, it is better for the safer side for the enrollment of patient. So that's why they say that uncontrolled, for example, HbA1c is approximately 12, or this fasting sugar is around 400 or 300. Then this type of patient, I will not recommend to incorporate into the pulmonary rehabilitation program. Patient safety is first on foremost priority, sir.
What rehabilitation technique can be given to a bedridden child with a recent history of hemothorax? For percussion cupping, should he wait until the hemothorax subside?
Sir, any effusion, pulmonary, this is contraindication. So in this case, the first hemothorax, we have to be taken care of this effusion, pulmonary effusion, and then only we can start breathing exercise and other things. At present, it's a totally pure straightforward contraindication for starting off any active pulmonary rehabilitation intervention.
Somebody use color code same and it will be different in different incentive spirometer.
Yes, sir. Yes. Depending upon the company, sometimes the first ball will be red. In some brand, the first ball will be blue. So it totally whatever the availability. The first ball which is going up, that is the least resistance. Second will be the moderate, and the last one will be the highest resistance. Now sometimes the single cylinder incentive spirometers are also coming up, where you can set the target, and that your patient is supposed to inspire. and then ball has to go to till that target. So a lot of new technologies are coming up right now in markets, sir.
In an average, in your department, what is the duration of pulmonary rehab program, and how many sessions you normally advise?
As I said, sir, once a week, thrice a week. Then when patient attends my department, patient spends approximately 30 to 50 minutes thrice a week for around 12 weeks.
Your approach to patient with respiratory failure.
Yes, the respiratory failure is again difficult, very difficult to manage. We are supposed to find out what is the cause of the respiratory failure. Until and unless you don't get these things, many times cardiac condition is the cause of respiratory failure, sir, or heart failure. This leads to this pulmonary hypertension and these things. As you can see, ATS guidelines, they say that especially for pulmonary hypertension, the pulmonary rehabilitation evidence is not good, sir. It is evidence is weak. But simply breathing exercises and energy conservation techniques, definitely we can advise and treat the cause of the respiratory failure and treat the patient accordingly, sir.
Any guidelines for TT care? How frequently we can do suctioning if the patient has more secretions? Tracheostomy care.
Multiple guidelines are available, sir. But again, I would recommend case-to-case basis here, especially in our setup, where the patient is come with a tracheostomy, whether it is of stroke or whether it is of high tetraplegia. We recommend every 3 hourly sectioning, every 3 hourly, sir. And we need to monitor continuously, see the oxygen saturation. Sometimes what happens, sir, if there is a secretion accumulation, you will see this harsh sound or some abnormal sound through the tracheostomy tube. Immediately, you are supposed to put this catheter and do the suctioning. It is totally a case-to-case basis, sir.
Is there any medications? Is there any medication to reduce the secretion? What medications
Yes.
do you use for that?
N-acetyl cysteine and multiple medications are available, sir. We can advise accordingly, sir.
Somebody has requested to tell something about the tracheostomy weaning protocol.
Tracheostomy weaning protocol is totally different class, different lecture, sir.
Yeah,
definitely. At my setup, we take help from this ENT specialist. A lot of our physiatrists who are doing ICU care, they do the downsizing and decannulation and then direct closure. Simply closure. So basically, without any oxygen, without any this thing, patient has to maintain the saturation for at least 48 hours. This is what we follow at here. At this thing, then we downsize the tracheostomy sizing, and if the patient without any complication, without any desaturation, patient maintains the oxygen saturation for 48 hours, and then we close these things. Okay. And prior that, we get the X-ray of the chest also to see whether there is any consolidation or any pneumonia is whether there is or not. This standard protocol everybody follows in acute care rehabilitation, sir.
Measures for secretion clearance in rib fracture patient, where you cannot go for percussion methods.
Yes, sir. In the rib fracture patient, as I said, positive expiratory pressure or PEEP device, definitely we can see. And in case of rib fracture, that particular bandaging and that, for example, if the 6th or 7th rib fracture on the right side is there, so we are supposed to tell the patient simply huffing techniques, slowly get the secretions out. Many times, sir, what I personally see, because I got a call from orthopedic also for the polytrauma and other things. Any percussion and any chest PT vibrator is totally contraindicated on the affected segment because it causes movement of the rib cage and it creates a lot of pain also. So that part we are not supposed to touch. Simple huffing techniques and postural drainage we are supposed to advise. We can advise a capillary device also.
Great. Thank you very much. There is no more question, and we have also exceeded the time. However, the presentation was very nice, and you have presented very practical way. The questions are also very interesting questions were asked in this webinar. It's a good thing that people are responding. People are interested to attend this, and really, if somebody has special interest on this, he can create his own recognition in this pulmonary rehabilitation field. Thank you very much, Dr. Harshanand.
Before end, sir, I would like to announce that our special interest group pulmonary rehabilitation, we are working on that. So our plan is that in phase 1, we shall be releasing a guidelines and there should be a support group. Those interested physiatrists who want to start their setup, we can guide them, we can mentor them, we can nurture them so that multiple site locations, they can start their pulmonary rehabilitation setup. We shall announce this thing in the first week of July, and actual recommendations shall be starting from the first week of August. Yes, sir. That's all from my side.
Yeah, very good initiative, Dr. Harshanand. Thank you very much. for your nice presentation and good explanation to all the questions of the participants. And special thanks to you that you are supporting us in all the way for conducting the webinar since last 3-4 years. And hopefully we'll continue with this, with the new segments and with new speakers. Thank you all for joining with us.
Thank you, sir.
And we'll close the webinar here. Thank you very much. Good night to everybody.
Thank you. Good night, all. Good night. Thank you, sir. Thank you.